8:30, and I'm going to go ahead and call the Pebb board meeting to order. This is our February 15th meeting, and welcome everyone. First up is I'm going to do roll call. Again, I'm Kimberly Hendricks. Greg Klauser.
Here.
Andrea Foltz.
Here.
Saban Martin. Not quite yet. Dawn Watner. I'm going to have to get that right. Not quite. Kate Nass. Sean Parkman. I say, oh, there's Saban. Okay. Sean Parkman.
Here.
Morning. Jeremy Vandehey. Okay, so I'll let Siobhan, you want to verbalize that you're in?
I'm here.
Good morning. Okay, so we're still waiting for a few to join us. I'd like to just take a quick, let's go ahead. I don't think I have enough people here for the minutes. Dawn, did you just join us?
I did. Good morning.
Good morning. Kate Nass. And Jeremy Vandehey.
You do have a quorum as of now, Kimberly.
Okay, perfect. All right, so the first agenda item is the minutes from January 18th, and I would entertain a motion.
This is Siobhan Martin. I will make a motion that we accept the minutes as written.
Thank you. Do I have a second?
This is Jeremy. I'll second.
Oh, good morning, Jeremy. Any questions? And then Greg and Andrea, you can't vote yet because the ink is not on your paperwork, but we'll go ahead and do, so Dawn, in favor of accepting the minutes as written?
In favor.
Sean Parkman?
Approve.
Jeremy, oh, sorry, Jeremy's already done that. Kate, did you join us? I guess then I need to vote. So I also support the minutes as written. All right. Okay, so as you all have noticed, we've got 2 new members, and I would love for Greg Klauser to just do a quick introduction of himself, and then we'll have Andrea introduce herself.
Good morning. My name is Greg Klauser. I live on the east side of the state, Umatilla, Oregon. I have worked for the Department of Corrections for 21 years. Currently, I'm a correctional corporal working at Two Rivers Correctional Institution in Umatilla, Oregon. Started working with insurance and DOC quite a long time ago. In 2015, most of you may have seen my name or seen me. I started working with the PMAC committee. Worked on the executive order, worked on all the HEM stuff that we just gave you, and have now transitioned over to the board, and hopefully some of my insurance knowledge, though seems small to me, but I do know quite a bit, hopefully it will transfer over so I can help out.
Welcome.
Thank you.
Good morning. I'm Andrea Foltz. I'm an associate professor of communication at Oregon Tech. More recently, in the last 2 years, I've been involved with labor negotiations with AAUP and also serving on faculty senate and other leadership positions within the university. I am excited to be here and hope that my talents, especially with communication and working in teams, will come in useful in making sure that we are compromising and working together. Thank you very much.
Welcome aboard, and thank you. We are very glad you're both joining our Pebb board. All right, good morning. Up next, and several of you probably heard them doing some introductions in the beginning, we have Vsp Network update, and it looks like Valerie is going to lead the team. I could be wrong, but welcome, Vsp.
Thank you so much, Kimberly, and welcome everybody. Good morning. I'm Vsp Market Director Valerie Swires. I've had the pleasure of servicing the Pebb account for 5 years, and in October I took over as the renewal responsibilities as well. Today I have two people with me. I have Jessica Clegg, Provider Network Development Supervisor, and Craig Rawl, our Senior Provider Relationship Manager. We've recently experienced some network disruption in Coos County, and with the termination of these 3 clinics, Bandon and Coquille Vision Centers and Coos Bay Vision Centers, with 3 providers. There were about 364 claims with these 3 locations in the last 12 months. And Ollie has asked us to come in and provide an update to the board, and we really appreciate this opportunity. VSP has very aggressive rural access requirements of 1 provider within 25 miles of a member's home zip code and availability for an appointment within 30 days. We still meet these. We have 2 other network locations with 1 doctor at each, a Walmart as well as Dr. James Cheslock in North Bend. Historically, we've been very competitive with our reimbursement fees for routine eye care. However, much like the increased fees that you're seeing in rural areas for medical and dental, these providers were asking for rates that were more in line with Medicare reimbursement rates for medical eye care services. And our objective today is to provide an overview of our current offerings, our utilization, historical claim trends, network access, as well as how our fees are negotiated and how those limits are crucial in maintaining our contract commitments. Year over year, we come in below Pebb's 3.4% cost increase cap, and we have many other clients that rely on a projected 3% annual trend as well. We will also outline the difference between routine eye care and medical eye care, the cost equitability impacts of increasing our reimbursement fees to match those of Medicare for medical eye care, and then our provider network strategy, critical solutions that we will allow us to address. I'm getting a lot of feedback. Sorry, guys. Critical solutions that will allow us to address member disruption now, but also long-term strategies for retention and recruitment. Pebb has been a valued client for 20 years, and we thank you for your business as well as your partnership. We just negotiated a 4-year admin rate renewal with a 3.5% decrease, as well as confirmed our annual projected claims trends of 3%. So we offer our signature network for Pebb members. This is our richest offering with the greatest provider access, our highest reimbursement rates, as well as negotiated discounts of 40% off lens enhancements. You offer 2 plans, a basic plan as well as a plus plan. Both of these provide an exam, lenses, and frames every calendar year. Members contribute a little bit more for the plus plan, and that gets them an additional $75 more towards their frame allowance and coverage for the top 2 selected lens options, premium and custom progressive lenses and anti-glare, and that is after a $20 copay for each. This is an average out-of-pocket savings of $235, and this is after our already negotiated 40% discount off of those lens options. So we have 42,488 that are enrolled in the vision plan. We have 57% that are selecting the basic plan, but we have a really high 43% that are enrolled in the plus plan. And a lot of this, a lot of those people that are picking that plus plan, It's because they can easily calculate what's their out-of-pocket savings going to be by paying just a little bit more, because you guys offer such a rich contribution. You're paying for the majority of the cost of the vision benefit for your employees. And then want to kind of look a little bit at your historical claims and utilization. And you can see here, we've got 2018, 2019, 2020, as well as 2021. And I think this tells a really great story, because you can see how from March through June, we did have a little bit of a dip in in that historical utilization or claim frequency. So the number of paid claims per 1,000 members per month. You guys on average run at about 120 claims. But during that time period, just like you saw probably in medical as well as dental and all your other insurance services, the claim frequency went down, and that's because our provider locations were closed. They weren't accepting patients. However, they quickly rebounded and opened back up in June and started taking appointments. And you can see through the rest of that time period, it really, really leveled off. And so very much in line with what we saw in past years. Just to give you a little bit of an idea about your frequency. So you have 120 claims per 1,000 employees per month. That's pretty high. This is about 37% higher than our book of business average of 91% for public administration SIC codes. And so your plan is very well utilized. And then when we look at those historical average claim costs, they have stayed very stable. And while this can fluctuate a little bit based on the percentage enrolled in the basic or the plus plan, it's been 3% or less for the last 3 years. In 2021, the average claim cost was 149, almost 150, and there were about 63,574 claims. This was 11% higher than we saw in 2020, but a better comparison is 2019, which was 2019 was 2% higher than 2021. And then I also want to reassure you that our access across the state of Oregon is strong. We offer private practice and retail locations with 741 providers at 376 locations. And our stringent network access requirements of one provider in 10 miles for urban and suburban is met at 100% of member home zip codes, and one provider within 25 miles is met for 97% of member home zip codes in a rural area. Average in-network utilization is 97%. I want to apologize on my slides. I had a typo, and one of my my partners caught this, and I was able to make this change before we presented. So I will update that with Rose. I do apologize. And if we carve out just the rural claims, you have 85% in-network access, in-network claims in the last 12 months.
Valerie, did you want us to wait till the end to ask questions?
Oh, no, please go ahead. We have the whole team here, and I think this would be a great opportunity for us to answer any questions as we're on a topic that makes sense.
Yeah, so I know you opened and shared some of the rural access issues and COOs in particular, and I know you were aware that we had a handful of members who had concerns because the vision centers closed. So I just had a couple questions on the previous slide when you talk about the rural access. I know that COOS is kind of a case in point, since that's the area that I'm more familiar with in terms of access, but you named that there were 364 claims in that county in the last 12 months. And so shifting that to 2 providers seems, you had 3 vision centers close, and that's a lot of providers to shift folks. It's very few providers to be shifting folks to. And we also had it flagged. For many of us who've been to the coast, we're well aware that 25 miles driving on the coast can be a long drive. So if you could name some of the things being done just to make sure, because sometimes it disguises how challenging it can be for folks to find the provider that they need, even though we're seeing that there's rural access within 25 miles, but we've been hearing it's been hard for people to get in.
Absolutely. So Yanessa is going to talk about our network strategy and some of the things that options that we are going to be putting in place, or that we can outline for you. But one of the things that I want to go ahead and share with you right now, and I'll go ahead and just transition to this next slide, because I do talk a little bit about this, is that in these counties that don't have access, we do have a policy in place that if they aren't able to, get in within 30 days. So what you just described is that, there's going to be 2 providers. And while some of these people may be willing to travel a little bit further for an appointment, if they can't get in and they don't have that access, they can call member services. They will provide an authorization for them to go to an out-of-network provider, and that when they submit their claims, they will be reimbursed up to in-network benefit equivalent. And so we have had a few people that have qualified for that, and we have put that in place for them. And so they were able to get in and receive the services that they needed.
And is that something that's shared with folks when you have vision centers shutting down, so there's disruption? Are people made aware of that so that they know they can access the out-of-network coverage for folks, for places that are closer?
Yes, we do share that. We do typically send out a letter that outlines, here is, the locations that are available, and then here is the here is our policy that if you do not have access, contact member services before you schedule your appointment, and then they will, and it kind of walks them through the steps.
Thank you.
You're welcome. Absolutely. And so, yes, and so you can see, we do have a few other counties that don't have access, but the majority of them border on a county that does have access. So just to give you an idea, Baker has 3 locations within 40 miles, 2 private practice and 1 Walmart. And then you can see Morrow, Sherman, as well as Weaver, these areas as well. We find in most cases, people are traveling for, other services. And so they're scheduling those appointments with those providers in the bordering counties. We don't get much feedback from these areas. So at this time, I'm going to go ahead and hand this off to Janessa Clegg, and she will speak to the differences between our routine vision care, medical eye care, and cost equitability, and our provider network strategy. So thank you very much.
Thank you, Valerie.
Welcome.
Appreciate it. So should I take control of the slide now? Would that be okay?
Yeah, that's perfect. If you can go up to the top, and that'd be wonderful.
Perfect.
Thank you.
All right. Okay, so you all can still see the presentation, right? While I'm talking. Can everyone see it? Okay, perfect. So I'm going to, I know we all really want to get into the Oregon network and some of the challenges that we're facing in our rural areas and solutions. We do have a lot of creative solutions for not just Coos Bay, but within the entire state. So I think you'll be really excited to hear about that. But before I jump into that, I just want to do a really quick level set. Make sure that we're all on the same page, maybe a quick reintroduction on the differences between a medical exam, medical services, and routine vision, which is the model that VSP is under. So go ahead and get to the next slide. So when a practice is establishing, and we're going to look at this from the practice perspective, when they're establishing their own business model, they're going to look to typically either orient themselves towards medical or routine. And some of the factors that are going to play into what that model looks like are the appointment times. We know that a medical appointment time is going to be a little longer. There are going to be diagnostic services and things like that that are going to play into that. Available medical equipment. A medical exam is going to have all of that additional diagnostic equipment that needs to be on hand in case those tests are needed. Staff resources, revenue streams, looking at whether they want to depend on that Medicare reimbursement rate for their exam as their primary revenue, or maybe considering doing routine and then getting revenue from the sale of eyewear and contact lenses and things like that. And then of course they're going to look at their member demographics and the population that they're looking to serve. But in those, just kind of keep that in the back of your mind as we look towards medical versus routine. Not all practices are 100% one or the other, of course, but they are typically a mixture of both. So it's good to understand where the differences lie. So I promise not to read into all of these, but really quickly, when a provider or even the office staff that's submitting the claims is looking at whether a claim should be medical or routine. The primary differentiator there is what was the reason for the visit? What was the chief complaint? If it is primarily something medical, eye pain, maybe even pink eye, something like that, object in eye, those things are all going to fall into a medical exam. But if they're coming in for routine vision, usually the reason for their exam is that they're there to prescribe vision correction. They're not there so much to diagnose and treat ocular disease. That's not to mean that they can't possibly detect it or detect other health issues, but that's just not the reason that those folks are coming in. So that'll determine whether or not it is a medical or a routine vision claim. And we talked a little bit, there's a difference there in the appointment times with medical exams. Something that's important to keep in mind is that medical decisions are required. And so medical exams are typically conducted by our OMDs rather than by your OD. And in fact, when looking at how many OMDs actually play in the routine vision care space, there are only about 15% of those MDs that are rendering routine vision. Primarily, their focus is medical. That's compared to our routine vision, where we see that there's really little to no medical decision making required. They're primarily conducted by ODs. Our ODs have lesser education, usually have saved on the expense of student loans a little bit more, right? So they're that kind of first line of exam, and then they'll refer to an OMD for a medical follow-up if that's needed. And so what we see is that our ODs are rendering about 85% of the routine vision across the country. So we're looking at a difference of, reimbursing OMD at that level of education, schooling, and experience, and then reimbursing an OD for a routine vision exam where that medical decision making isn't required, the diagnostic tests typically aren't incorporated, and that all kind of factors into the appointment times and the costs. So looking at medical again, just to compare, the member out-of-pocket costs are higher with medical, especially since Medicare doesn't reimburse unless you're looking at, C or supplemental coverage. But the members are typically going to want to go in for routine vision. They are going to avoid the out-of-pocket medical deductibles as much as possible. And so we see that along with, how often those medical exams are needed is that only 17% of eye exams are ever medical. Routine vision benefits are going to carry really high utilization rates because those are members that typically have an exam covered in full or pretty close to it. The out-of-pocket costs are very low for them, and they're going to utilize that benefit. And then I think it's important just to lay out that the ODs are limited to their scope of practice. And so that's typically why they're routine vision, where the OMDs are able to render additional services, especially in the state of Oregon. We'll talk about it a little bit later, but in the state of Oregon, ODs are trained a little beyond the allowable scope of their practice, and that's actually a source of contention in the network right now. But basically, where that all kind of rolls up into is that our medical eye exams are not often considered a primary revenue source for OD managed practices. Typically, our ODs are going to focus on routine vision. They're going to look at the revenue stream that comes in from that, which is not just the vision benefit, but also the optic sales, the eyewear, contact lenses, and things like that. And just to give you an idea of what that looks like, our private practice ODs capture 73% of eyewear purchases nationwide. So that is really the source of where those eyewear purchases are going, and they're filtering through our private practice ODs. And so they're leaning really heavily on that revenue source traditionally. And then I'll skip forward here. Do we have any questions? Because I know I'm going through this really quickly. Trying to make time. So the difference in those, ultimately 99% of our business is routine vision care. We're rendering a vision exam to an OD who is practicing within that allowable scope of practice. The appointment times are shorter. The overhead costs are generally less for that OD or even the OMD if that's who's rendering the routine. And the primary focus of revenue is not going to be from the high medical or Medicare reimbursement rate, but from the routine reimbursement plus the optic benefits, which are those eyeglass lenses, contact lens sales. And without jumping too far into this, just to kind of give a little more insight to the network in Oregon today, there is a sort of a shift that we're seeing out in the network. And ultimately what it is the Oregon Optometric Physicians Association. They recently submitted a bill, it's HB 2541, and they're pushing to expand the optometric full practice to perform some additional procedures. And where that's at is they submitted the bill into 2021, but ultimately they're looking for the ODs to be able to increase their scope, increase the revenue that's available to them, especially with some of those medical services. And that's kind of in response to what they're seeing across the country, which is that in many other states, we're seeing that OD scope of practice is getting broadened. And so they're leaning on those medical services and those high reimbursement rates more and more for revenue. So it's a total shift, not just in Oregon, but across the country, where our ODs are looking for those higher medical reimbursement rates. And so now that we've kind of laid all of that, talking about cost equitability and how that plays into our fee model. So we know that VSP, we guarantee our lowest out-of-pocket costs. We try to keep premiums low. In the state of Oregon specifically, especially talking about Coos Bay, one of our recent fee reimbursement offers was within 20% of the Medicare UNC and 50% of the practice or the medical or practice UNC, and what they would typically assess even for medical exams. We feel that that's pretty competitive, especially when you look at the difference, again, between the routine vision exam that we're reimbursing for and the medical exam that you're seeing with medical and sometimes Medicare. We also provide a revenue stream with our premier benefits and our optic sales, but we'll talk about that a little later too. So if we increase those fee reimbursements to what they're asking for today, which is closer to that medical and Medicare UNC, what we would see is that claim reimbursement would carry over to the claims costs, which would of course have that financial impact on you. And so in order to kind of keep that balancing act of reimbursing the providers, with the revenue that they're looking for, while also keeping your claims costs low, the Vsp fee strategy is to try to leverage provider revenue from other places. So rather than increase a provider's exam fee, for example, which would directly correlate to your claim cost, we might come in with our Vsp Premier program and say, well, actually, we're going to give you this bonus on selling these frames, or there's going to be incentives for selling eyewear or identifying chronic health conditions. If you're rendering a thorough exam and identifying a health condition, something like diabetes or hypertension, then that's something that we'll offer a financial incentive for. And that's coming from VSP's pocket. It's not something that directly carries over to your claims costs. And so there's a few other things we do just to kind of talk about that Premier program and where we're pulling revenue for the practice. We financially support practice remodels. So we have, designers and financial support that'll come in and support our private practices with remodeling. We invest in the success of their practices. So for example, through COVID, obviously a lot of doctors had closures. There were, they took a large hit. From 2020 to 2021, VSP granted or issued over 9,000 grants to our private practice providers, and those were grants up to $10,000 to support them in reopening their practice, obtaining the necessary PPE to continue practicing, things like that. And then there's a ton, those are just some of the examples and the ways that we provide financial incentive. And did I see a question come through, Greg?
Yes. Jessica, you were talking about the basically what I consider it is like the eye mapping, where they're able to tell if you have sugar diabetes or other things, and you were talking that those incentives go to the provider, correct?
Yes. So if they are able to detect, that chronic condition, then that would be paid to the provider on the claim. Yep.
Okay. My question is I know through mine and several other people that I have talked to throughout the state, the eye mapping, what that's considered, we're still paying for that 100%. It's not ever been covered by VSP. Is there a look in the future for that to be covered?
I think so. I think we're open to everything.
And
I don't know that there's
happy to answer that question.
Oh, do you, Valerie? Okay.
Yes. So, that is something that some of our groups do offer, that we can, write that into the contract and let you know what the projected, impact to claims costs would be to cover that either in full or lower than the now negotiated not to exceed $39 fee for the.
No, that's fine. Okay.
Thanks, Valerie. I shouldn't have tried to answer a product question.
That's okay. No
That's
worries.
not my area. All right. So looking at providers, though, so that's where VSP has gotten really creative, especially in recent years with the rising costs and the pandemic, to show our providers our commitment to their success, financially invest in them, offer a ton of financial support. We also offer, even staffing resources. A lot of times I was working with a practice in Stockton, California recently, and they were looking for another OD to come on and would typically have to pay about $20,000 to, the headhunter services to bring them in a provider. And VSP was able to support with that and recruit on their behalf. And, that's a $20,000 savings. They were able to get a new OD in place and everybody wins. But, never something that was going to carry over to claims costs. So we feel we have a great solution there. And it's really important when we're working with our practices who are asking for those reimbursement rates. That's a heavy part of our conversation. We're going to try to avoid those exam reimbursement rates in those increases, but let's see how we can find you revenue somewhere else. Okay, and so I'm going to move into where we're at with the solutions in Oregon. Do we have any other questions on medical versus routine or our fee strategy before I jump into that? Okay, all right, no objections, so go ahead. So in Coos Bay especially, but in some of the access or the areas that we have access issues, oh, I think my slide just went away. Did that drop for everyone else?
Yes.
Not sure how to bring it back up.
No, I got it.
Okay.
I don't know why it dropped, but it did. There you go. We're back where you were.
Wonderful. Okay. So one of the solutions that we're looking at, and this is a new solution for VSP. This is not something that we have generally done before. But in areas where we have access or availability issues where, like Saibon mentioned earlier, we may have so many claims and only 2 providers, and that's not going to carry over to a great experience for the member, right? If they have to wait 2 months out for an appointment. So we want to avoid that. We still want to increase the access, whether we meet the access requirement or not. It's important that there's enough availability for the practice to be able to see our members. And so one of the options that we have to talk about today is the possibility of bringing in a group approved provider, or what we call a gap provider. And what a gap provider is that's an agreement between the provider, VSP, and the client to render services to that client's members. And so this provider would not be considered in network for VSP. They would not be open for all members to visit, but they would be contracted to render a specific VSP population. And that agreement, or that contract, is not new for us. We've had gap providers before, but now what we're going to sort of allow clients to play a larger part in is the consideration of meeting that provider's negotiated rates. So if that provider and VSP are unable to meet at a place for where we're at in network, but the client still feels that it's critical that that provider be available to their members, maybe, for example, Bandon and Vision and Coos Bay, we can agree or offer to pay that practice at the rate that they're asking for, specifically for your members. And what's going to happen if we do that, of course, is that that's going to carry over to the claims cost. So there's going to be a financial impact. We've done a few calculations, just kind of looking at what this arrangement would look like. And depending on the client, we're seeing financial impact of everything from, $5,000 to $7,000 a practice to up to $50,000, depending on what the traffic looks like. And so what we'd like to do today is extend that offer and just kind of put that in your mind as an open possibility, is that if we do have a practice like in Coos Bay that is demanding a fee reimbursement rate closer to medical and Medicare, VSP will agree to do that on your behalf and negotiate that contract if that's something that you'd like to pursue.
So this is Siobhan again. So I just want to make sure that I understand. So this is something that we can consider doing as a board
Yes.
if we want to do that. And it would only be available to specific individuals in an area, or specific populations, like the Pebb population in Coos County, for example.
It would be by the group. So by the entire, like the client base, any of your members, and I'm sorry, that was my timer. Any of your members would be able to see them regardless of whether they live in that area or not. If they're covered under your benefit, they would be considered in network for any of those.
Okay, thanks for the clarification.
Does that answer your question?
Yeah.
Anyone else?
Of course, before agreeing to anything like this, you guys would do a negotiation and give us an idea of what each individual place would be, and then as a board, we could decide if that's something we wanted to move forward with.
Yep, and I think we've done that. I know we've had some pretty lengthy conversations around Coos Bay already. So those negotiations, I think, have about ended, but we can now, if you would like to enter a new negotiation for a gap contract, we would go in with those numbers and negotiate those.
I just have a process question for Ali. What would this look like for our board to make a decision like this, Ali?
Well, I mean, I think you can take action and make a decision. I don't know that we've really looked at any of the downsides of doing it all that closely. We could present that, do a little more research first, and then present a recommendation, or bring VSP back to the next meeting. And we can obviously make it part of the round 2 of the renewal and request more information from VSP.
Thanks.
Yes, Ali, absolutely. I would be happy to, kind of outline those things offline after this meeting, and just some action items and what you would need from us, and then communicate that back with the broker as well.
Yep. And one quick item just around timing. For some of those providers, especially in Coos Bay, that were already credentialed with VSP, and may not be terminating yet, or if one were to term, we can implement this contract pretty quickly so that the provider doesn't have to go through the credentialing process with VSP again. But if there is a large gap of time, like over 90 days, or if we have new practices that we identify that you'd like to gap that maybe weren't on VSP Network, just keep in mind that there would be somewhere around a 60-day implementation timeline for them to be credentialed.
So essentially, the ones that terminated January 1st, we'd have till the end of March for them not to have to get re-credentialed if it's a 90-day gap.
It depends on the practice. Some of them, yes, if they actually terminated on 1/1. I'm thinking of some of the Coos Bay practices, but yes.
Thanks.
Yep. So it'll be definitely case by case basis. All of these, as they come in, as you identify practices that are critical, we'll approach each of them, one at a time as they come up. Okay.
So this is all wonderful conversation. We're at the 10:10, so I just want to let you guys know that I see a lot of slides are still left to go. So
I think if it's okay, we can jump right into recruiting if you'd like to see the recruiting strategy of what we're doing to fix.
Or do you need us to wrap this up in like a minute?
Yep.
Well, we usually give a little wiggle room, but I just can't go too long because then it throws the entire morning off or morning.
Well, that's okay. I think we can wrap. We can send maybe a summary overview of what we're doing to recruit in the network, and you can take a look at that. Would that work?
Thank you. Yes.
Okay. Sounds good. All right.
Thank you, everybody, for your time. We will stop presenting, and we look forward to future follow-up action items.
Excellent dialogue. Thank you very much, all of you, for being here today.
You're welcome.
Thanks, everyone.
Thank you very much.
All right, so next up is risk-based capital report, and we have Emery joining us. Good morning, Emery from Mercer.
Morning. Hi, thanks. So this presentation is the risk-based capital presentation or risk stabilization fund update. As we, there are a couple of new board members, or actually, I guess 3 that have probably not seen this presentation before. I want to provide a little bit of background as to why we're showing this report. So moving on to the next slide. So what is the purpose of this report? So what we're trying to do is we're trying to take a look over the, I guess, 21 through 2025, whether Pebb has, what the funds are that are inflows into Pebb, and whether they're sufficient to cover the costs that are coming out of the Pebb. So what we do is by year, we take a look at the claims, project the claims out, take a look at 21, project 22, take a look at 23, and then 24 and 25, and then compare that to the funding that's coming into Pebb. Not only are we looking at the difference between the claims and the funding, what we also want to do is to make sure that since Pebb is self-insured for the majority of the cost, that the potential fluctuations, the different, the potential increases, decreases in cost that happen from year to year, that Pebb has enough reserves to cover those potential fluctuations. And how we do that, and how Mercer does that, is by taking a look at what we call RBC, or risk-based capital, which we'll have a little bit more detail on the next slide as to what that is. But it's like a calculation for essentially how much liability, how much volatility potentially there is in the self-insured costs. And we provide a range of risk-based capital and the target, and based on how much reserve Pebb has in relationship to the target, basically says whether you're well funded enough to deal with the variability in the self-insured costs. That range was developed based on historical fluctuation in Pebb costs, as well as doing some Monte Carlo simulations, where we essentially simulate the randomness in the claims based on Pebb data, and it kind of gives you an idea of how much volatility you should expect from year to year. And this report, which we provide semi-annually, kind of monitors this once here, right prior as we're starting the renewal process, and then later in the year following the renewal process and when we get more claims. Any questions? Okay, moving on. So what is risk-based capital? So it's a way of measuring the minimum amount of capital that's appropriate for essentially insurance companies. So it's from the NIC, or the National Association of Insurance Commissioners. They created a formula to determine the minimum amount of capital, or just funds needed to be appropriate for those insurance companies. And Mercer took that and applied it for Pebb. Essentially, you're sort of running your own healthcare plan, and so based on the medical, dental, and vision formulas, we kind of calculate the amount of reserves that can be there for us a cushion against the volatility in this case. The risk to Pebb is really underwriting risk, and so what is underwriting risk? On the next slide. So what is underwriting risk? It's basically what we do for underwriting, which is the process we're going through right now, and we'll have some of the additional results in the next presentation. So we take a look at base year claims, and in this case, it'd be 2021. And we then apply underwriting, which is applying trend, program changes, any other changes to then project out to a certain time period, which is in this case 2023 for the renewal process, and also in our fund update, we project out 22 as well. We project out 22. But that underwriting process does bring in potential volatility, potential areas where Pebb is subject to risk. In this case, some of the areas of risk are there on the right. The trend rate. Are we using the correct trend rate? That's always a question. Trend is made up of various components. With VSP, they're talking about the unit cost, right? With providers, some providers, feeling like their reimbursements, their unit costs aren't big enough, and they want to get more money. And this is also another potential area, especially during the COVID-19 pandemic, where nurses are harder to find. They're leaving. Staffing is harder. People are resigning, don't want to work in healthcare, they're getting burnt out, they want to get, people are getting paid more. So what kind of pressures is that putting on the unit costs in reimbursements in the future? So, if costs go up, your trend is going to go up in that case. Population risk. So the base year claims is based on the population from 2019. Is that, or 2021 in this case, is that the same population that you have in 2023? Pebb, how much is Pebb changing? Are new entities coming in, new entities leaving, people retiring? How's that impacting your population? So it could be up or down in this case. Older people retire, you have younger population, lower costs, makes you look better. But if a lot of younger people are leaving, your costs are going to be higher because the older people tend to cost more. Legislation. There's a lot of legislation going on in Oregon right now. So some of those are potentially impacting Pebb starting in maybe July of 22. Also national legislation as well. So over-the-counter COVID test. So that's something that was, mandated as being covered under the healthcare plan. How's that impacting Pebb? It does have an impact. And so while we're projecting out 22 reprojecting out 22 costs, those weren't necessarily built into funding rates for 22 because we didn't know about it until essentially a month ago. Environment and pandemic. I guess, this for this presentation, we kind of talked about having a reserve to help account for the issues of a pandemic. And there are additional costs, with the vaccines, testing, additional treatment costs. But I guess we didn't really necessarily anticipate that people would stop going to the doctor or change the way they did use services the way that they had. So in some cases, this pandemic's actually resulted in additional savings, which were reflected in 2020 and 2021. But for 22 and 23, how is COVID going to impact Pebb? How is COVID going to impact healthcare in Oregon? And is there going to be a return to services in 22 and 23 that weren't reflected in the claim space that we're using for 21. So this is actually, I guess, an area of concern for me, because Mercer has been projecting out, well, for 21, it looks like maybe some of the costs, you still have some reduced utilization as Delta and the Omicron virus potentially brought down, made it more difficult for people to go and use services, or they didn't want to go and use services, or with elective surgeries were not possible because there were a lot of people in the hospitals with COVID, and they were restricting the types of services that were being done. So how much has that impacted the 21 claims, and how much of that's going to bounce back in 22 and 23? So some of the risk-based capital, this fund is to help account for that, but the question is how much is going to come back, and so that's a big area of risk for Pebb. And then the final one listed here is large claims or random fluctuations. In many cases, large claims are random. Sometimes you don't know who's going to get cancer, who's going to break a leg in an accident, those sort of things. So some years you have more large claims than others, and so there's some fluctuation going on as well there. Any questions? Okay. So what are the results of this update to the Risk Stabilization Fund? So for 21, as mentioned earlier, there were more deferred care than what we had projected, and so as a result, the fund balance, the difference between costs and funding for Pebb was a result of an increase of $36 million. So basically, you had $36 million more in funding compared to the cost that went out. So there was a surplus of about $36 million. The total fund balance did close at $334 million as of the end of the year. There was a $63 million transfer due to House Bill 2377, so that actually ended up offsetting the fund a little bit more than what was brought in as a result of surplus. For 22, we do project a little bit lower costs, and the net difference to the stabilization funds about increase of about $4.6 million. The surplus, the difference between cost and funding, was about $10 million, and then there's a additional $6.3 million that we're anticipating as a penalty as a result of the $63 million transfer from HB 2377. So because of some of these funds are federal, there's a penalty for essentially transferring healthcare funds into a general balance, and there's additional penalty that's paid the year following. For 23, basically the costs and the funding are about the same. So the ending fund balance is going to be basically the same, essentially at $339 million. So there's no real big change to the ending fund balance. And then 24 and 25, the trend rates, the market trend rates we're using are actually going to be higher than the 3.4 projected funding that's Pebb's limited to. So as a result, the cost increased by more than the funding, and then the funding end balance decreases in 24, and in 25 essentially ends, well, $2 million below the reserve target, which is in this case actually pretty much right on the reserve target. Okay. Next slide. Just a little description of the current fund balance. So Pebb has approximately $403 million in their general ledger account. Not all of it is for the stabilization fund. Some of it is like allocated for example, operations there at the top, some FSA funds from the members, and then IBNR, so reserves that are essentially run out claims for the medical plant, and that represents the biggest chunk of it, about $66 million. There's a little bit that's tied to some of the fully insured plans, and so as a result, about $70 million of the fund balance is limited for those items. And so the net result is about $334 million in the stabilization fund reserves, which are then used to offset potential fluctuations in the Pebb costs. The 2021 target that we set was about $240 $334 million. So essentially the difference between the $334 million and the $204 million, which is $130 million, is the net difference or the amount that you're above the target. So essentially you have a buffer of $130 million as of the end of 2021. Next slide. Taking a look at it by year, this chart kind of shows you in the purple, the top purple, the ending fund balance. And then the pink that's increasing is the reserve target. So on the far left, the ending fund balance is about 334 million, and the reserve target, as mentioned before, was about 204 million. So the delta there is $130 million, which is how much you're currently above our target. So this is based on 20 claims through December 21, and for 22 through 25, we use the January 22 enrollment to project out costs as well as the reprojected costs. And then for 23, we have initial projections of self-insured costs as well as initial results from the renewal. So that's actually, the most up-to-date information that we have. So for 22, it's the reserve target does increase due to trend and expected cost increases. The ending fund balance actually kind of stays about the same because the funding coming into Pebb is enough, is just basically the same as or just as mentioned earlier, I think funding is a little bit higher than the cost they're coming out of Pebb. And then for 23, it still remains pretty flat. But then, as mentioned earlier, trend starts overtaking the funding increases for Pebb. And so the ending fund balance does drop in 24. So the delta there is about $70 million. And then on the far right, the two lines basically intersect. So you're basically the reserve target and the funding balance is about at the same place in that case. So, overall, Pebb's in a pretty good position, but does mean that, the market trends, which we're using 5% for medical and 10% for pharmacy, dental and vision are a little bit smaller, 3 and 2% for the self-insured. So it does mean that, the medical costs are still above the 3.4% trend, at least what we're projecting, and you need to keep that in mind for future years to try to keep the trends down and keep the fund balances above the 3.4% target. And Ali, you have a question?
Yeah, thanks, Emery. Just wanted to confirm, so this doesn't include the RSR, risk stabilization reserve funds that the board set aside to kind of fund the bounce back or the fluctuating claims, correct?
Yeah, you're gonna have to remind me how much is currently in there.
I'll have to check, but I think it's over 30 million. So yeah, we can follow up on that. But yeah, that is something that we've kept separate from the reserve, but the board has set aside for the increase that we know is coming as things get back to normal.
Yeah. Okay. Yeah. Okay. Any other questions? Okay. Next slide, please. So this just kind of shows the difference between costs and funding for on a per employee per month basis for Pebb. So on the left, we have 2021, and the costs are in blue, and the funding's in green. So the costs are lower than the funding, so that's building up a surplus in 21. And then 22, the surplus is a little bit less. And then you can see 23, 24, and 23 is about equal, and then 24 and 25, the costs start to increase or outweigh the funding. And the percentages down below kind of show you the changes in those components from year to year. So, on 21 there on the left, the costs increased 9.1%. That's obviously a lot bigger than the 3.4%. But on the next slide, we'll show you really it's a bounce back. So why don't we move to the next slide? it's really a bounce back as a result of the pandemic. So this slide kind of shows you the historical cost increases for Pebb from 2018 to 2023. So 2018 was a little bit worse of a year, so that cost increased 6.3% compared to 2017. But then 2019 cost increase about the same as 3.4%. And so if you kind of keep that 3.4% growth in the green line, you can see the costs as they could have been at 3.4%. But for 2020, well, COVID happened starting in late February, early March. And as a result, services did not, a lot of services were deferred, canceled, delayed, and the costs for Pebb were well below. And as Ali was mentioning, there's a bounce back as due to these essentially abnormally low costs. Some of it was seen in 21. So the bounce back was a 9.1% cost increase, but still keeping you well below that 3.4 growth line. But for 22, as mentioned earlier, there's still probably going to be some bounce back because 21 had the Delta and Omicron surge, and those, did impact healthcare. Services were being deferred, hospitals were being filled up, and and then there's additional pressures, right? Additional tests being performed, additional services, and booster shots and additional new vaccinations, hopefully. So those additional cost pressures are there in 22. Despite that, we're still despite that and a 6.9% increase, we're still below that 3.4% trend line. And then for 23, with the new results and additional costs, the cost increase is about 5.1%, but still over the past 4 years, the growth has been, annualized growth has been less than that 3.4%. Any questions? Okay. Slide 10. So another look that we do on the risk stabilization fund is to take a look at what would happen to the fund if you did keep costs at that 3.4%. And the results are, as better than what would happen if costs still increased at market trend. So on the top, on the graph in purple, the ending fund balance would essentially keep at that $340 million level, while the reserve target would increase, and increases a little bit slower because your costs are increasing at a slower rate, but the delta remains, about $100 million, and well above the reserve target if you can keep the cost down at the 3.4% range. Okay. I think this is probably going to be the final slide we'll present in this for today. And it's just talking about the data and some assumptions and methodology. So the data, as mentioned earlier, we use claims through December 21, then we reproject out 22 and 23, and then use market trends in some cases to project out 24 and 25. For medical pharmacy, the weighted average is about 6%. Some fund adjustments. So there were vaccines incentives. The latest information was about $3.6 million in vaccine incentives. So those were taken out of the stabilization fund. And then some of the surcharges that the employees are paying, a little detail around there. And then, the projections, as mentioned, it's like we're using the claims, and then we show the projections based on either the market trend rates or 3.4%, depending on the scenario. That's actually, I think I'll open up for any questions. Yes. I think you're on mute.
There you go.
How about now?
Yeah, we're good.
Excellent. Thank you. Thank you for that presentation. My name is Dawn Mautner. She, her, a white woman, long brown hair. And if you wouldn't mind going back a slide or two, I think that I serve as the Medicaid medical director and I'm a family doc, and the way that you describe utilization of services makes a great deal of sense to me. But if you could go back a slide or two, I'm waiting for the other shoe to drop, like I think a lot of us are, right?
Okay.
We saw this drop in services due to access, and what we're seeing now is the bounce back. What's next? And are we going to shoot past our 3.4%? And what are we doing to both to predict that and to manage it is my question. Thank you.
Yeah. So Rose, I think maybe, was it 2 slides back?
The one with the trend line. Yeah,
This one.
that's the one.
Yes. So that's a really good question. I think we're trying to monitor it. We're trying to monitor exactly how much of this cost decrease is really canceled care, depressed utilization that's going to come back, versus potentially changes in the way people are utilizing services, right? The emergency room usage is way down. Urgent care usage is up, which is good. I mean, I think that's something that people had wanted to do for a long time, and it's finally happening. How much is that's going to happen or keep going? Telehealth utilization's gone way up. Telehealth utilization of services has kind of remained high, especially in Kaiser, but it remains high in the other self-insured plans. I think the cost for some of those services, I think telehealth utilization is about the same. So it's not really, you're just kind of shifting costs from one place to another, but potentially there might be some efficiencies there. I think lab services may be a little bit lower if for telehealth services versus not. And then I guess the one other thing that we've talked about a lot is behavioral health utilization. A lot of telehealth behavioral health utilization, a lot of just general behavioral health utilization has been increasing. How much more is that going to increase? Is there going to be access and people are going to be able to use services, and how much is that going to impact it? But then I think, so those questions are things we're trying to monitor. It's kind of been keeping along in 21. I think in 22, I don't know. There's some usage. I think with the different waves of COVID and how people are responding to COVID and number of people unfortunately having to be hospitalized because of COVID, that's a great unknown. And that does impact hospital utilization. There is probably going to be a bounce back of services. I think we saw some of it for elective surgeries at the beginning of 21, but then I think it started dropping off again as the hospitals basically shut down. So are we going to see another bounce back in 22? Is it going to be more sustained? And whether hospitals have the capacity or the staffing to actually deal with that as well. And we're trying to, I don't know, you might have a better answer than I do. I think we're trying to monitor it, and we're trying to keep that in mind. And we have put in a bounce back for 22 for Pebb, and that's part of the reason why the growth is 6.9%, which is higher than trend rates. So we are, I guess, putting in some conservatism to account for that. I guess the next step is what can Pebb do to understand those costs for 23, 24. And
yeah, thanks, Emery. And Dawn, this is Ollie. And without getting into too much detail, I mean, I think this year we're going to be ramping up on value-based payment arrangements, total cost of care. So we're not putting the board at risk or exposed to, some of the trends, the commercial trends that keep going up. Centers of excellence is another way to control costs and get our arms around some of the unit costs issues that we're experiencing. And but yeah, I think you'll hear a lot more about 2023 in the next presentation, and we'll definitely go from there.
And this is Stephen from Mercer, Stephen Eldner, and I just want to put in a plug for population health management and the well-being efforts that PMAC and the Worksite Wellness Coordinating Council are working on. We're going to have a presentation a little bit later about that, but in the long term, utilization demand is a way to control cost, right? And if we can get more people to be more healthy and more aware of their health and well-being and find ways for them to be supported in that, we think that, and we know that historically that can make a difference in the utilization and the total health burden and cost burden for the board. So we'll keep that in mind, work at from that end as well.
Yeah, just
Thank
to
you. Sorry, go ahead.
put a fine point on that, the faster we can get certain screenings back up to where we want it, the faster we will know the size of the bounce back. Because what's really going to get us is those cancers we failed to detect on schedule and that are now currently becoming worse, and also diabetes. Pre-diabetics that have now converted to diabetes that do not yet know, are not well managed, etc. The faster we can get those people into screening, the better understanding and picture we will have about our actual risk profile.
That's a really good point, and I appreciate all of the thoughtfulness going into it, this presentation. The last point I'd like to just leave you with, because I know we need to move on, is the equity implications of this conversation. I would be interested in seeing some breakdowns by demographics within our populations to see who we're missing most, who's accounting for what, and who needs some sort of targeted support in order to really get toward addressing our 2030 goals of eliminating health inequities. So if in future conversations we could bring some of that information and talk about it, I would appreciate that. I'm not sure how others on the board feel about that. Thank you.
Again, such excellent dialogue among everyone. Thank you. I'm just so excited about our board right now. I'm so grateful for all of you. Emery, thank you so much for presenting our RBC report. And we are going to go ahead and start with renewal responses round 1. So Mercer, you're up again. And we do have a break built in, folks. So if we can get through this round 1, then there is a break. So thank you all so much.
Hi everyone, this is Andrew at Mercer, and we'll try to stick to time so we don't eat into that break. I think we've got an hour, which I think will be plenty of time. So in addition to myself, I've got my colleagues Emery, who you just heard from, Mitch Nigro as well, are going to be chiming in here as we go through these slides. And so as you can see on this slide, this is round 1. We'll have rounds 2 and 3 in the next 2 months, so March and April, and then final decisions will be in the April-May timeframe. And so in addition to some renewal stuff, we do have a couple of other things in here. There is an item where we're going to request board action. We'll get to that here in a couple slides. Emery will provide a little bit more information on preliminary composite rate increase in 2023 and how that's comparing to that 3.4% cost cap. We'll look at the plan performance for the self-insured plans in a little bit more detail. And so it's a good way to sort of check in on those plans from a financial perspective. So we'll look at expenses for those plans compared to the accrual rate that had been set for those plans. And then probably where we'll spend most of our time is in the actual program renewal details, which is the second half of this deck. So Rose, if you could move us forward. I think we can actually jump to the next slide too. Yeah, thank you. Oh. Sorry, could you go back one slide, Rose? Looks like the content's not showing up there. You know, that's okay.
Andrew, I think I'm having computer problems. Can you just share your screen? Can you do this?
Sure. Yeah. Let me get it. Let me get it queued up here.
I'm about to get kicked off anyway.
Okay. Okay.
Andrew, I have it open. I can just share my screen.
Okay, that'd be great, Mitch. Thanks. And this is a slide that most folks will seen, but I know there's some new board members, so it's good to sort of revisit this. And it's actually sort of a perfect time to reconsider the guiding principles, given that a lot of this discussion is looking at potential program changes for 2023. And so as Mitch is pulling this up, I can just speak to it a little bit. And so these guiding principles can sort of be used as a reference document and almost a decision-making tool as we're considering program changes for 2023. We can sort of bump them up against these guiding principles and ensure that they are strategies or tactics that sort of fit within this. And so this is definitely a good time to sort of reconsider this document. The foundation of it is the triple aim, which you see across the top there. So improving the quality of care, improving the patient experience, delivering care more efficiently. The state of Oregon, via the governor's office, they have their own priorities within the triple aim, which you can see in that sort of tan colored row. OHA guiding principles as well have been included and broken out within this sort of framework of these three buckets. And then, of course, we've included the Pebb vision as well. And so that outlines at a very high level what are the goals of the benefits program as it relates to the triple aim, with a focus on three sort of primary stakeholder groups: patients, so your members, healthcare delivery system, and then the needs of the plan sponsor itself as well. And so, you know, I won't read through this in great detail, but some of the Pebb vision things are items are things like innovative delivery system, evidence-based medicine, improving quality and outcomes, accessible care, equitable care. And so again, this is sort of a handy tool, especially at this time of year, to sort of frame all the program changes that you all are going to have to weigh in on between now and April and May when final decisions are made. So Mitch, if you could jump to the next slide. This is another sort of a decision-making tool in a sense. And so these are the health equity strategic pillars that the board decided on in late 2020. These were the result of a board retreat. And so again, as we're considering these different program changes for the renewals for 2023, this can be used as a decision-making tool specifically with the health equity lens. So is a given change advancing the board's goals from a health equity perspective? And so this wasn't the only result of that board retreat. There were also a couple others. The health equity subcommittee is now up and running. There's a health equity screening tool, which we have applied to a couple of the renewal items that we'll talk through later on in this deck and then in the coming months as well. So another good sort of reference document as we're going through these next few months and talking about changes for 2023. Okay, as promised at the outset, there is this item here where we're requesting board action. This one is around coordination of benefits, specifically for benefits that are have a benefit limit or a cap. And so we've got some examples there in that sort of dark blue row across the middle. You know, fertility benefit, for example, has a benefit cap of $35,000 per year. Some of these other benefits like, you know, acupuncture, massage therapy have visit limits. So maybe for acupuncture, it's 12 visits per year is the limit that the plan will cover. And so what we've sort of uncovered here and what we're going to ask you to weigh in on is that these benefits are not being administered consistently across your three medical vendors. And so Moda and Kaiser are allowing folks who are double covered. So if you're covered through your own plan, you're also covered through your spouse's plan. Moda and Kaiser are allowing members to sort of dip into that limit 2 times, right? So on your own plan and then your coverage through your spouse's plan, your partner's plan. Providence, it hasn't been set up in that way. And so the Mercer recommendation here. Oh, yeah.
Maybe not.
Sure. Sorry, was there a comment? And so the recommendation here is to align Providence with Moda and Kaiser, so that if you're a member enrolled or double enrolled in Providence, you can dip into those benefits 2 times, once for your own plan, once for your partner's plan. And so that would create parity. It'd be a little bit more of an equitable way to treat members so that regardless of what carrier and what plan they go into, these capped and limited benefits are being administered consistently across all 3 carriers. So let me pause there and just see, what questions and comments there are.
I just had a question about whether this was did we expect that to happen for all of our benefits for them to be aligned around double coverage? Was that the expectation? That was the expectation of our trend rates based on that? I mean, I don't know how much this impacts, but the parity certainly speaks to me that they should all be administered the same.
Yeah. Yeah, and so I'd ask my teammates to chime in here because they might have more history on it, because I think that this was first uncovered before I joined the team, but I think that it was not intentional. I think it was something that was uncovered through some comments that we received from Providence members. So my understanding, there was never an intent to set it up in this way. I think we're trying to correct for something that we learned about, I want to say, a couple months ago.
Yeah, that's accurate, Andrew.
Thanks, Ali.
Yeah, so the cost impact here would be marginal because take fertility, for example. So the members are already paying double premiums and then you're collecting that from the agencies. So today on Moda, if there's a couple dual enrolled on both Moda plan, or one couple's, dual enrolled on Moda plans, you could get up to $70,000. So each spouse or each person in the couple is getting the $35,000 benefit. And so if you're on Providence today, and you're dual enrolled, you're only getting up to that 35,000. So there's a whole 35,000 that are missing if you would have had enrolled in Moda versus Providence. So technically it's the costs are already baked in because when we're doing our underwriting, we're assuming that in the employee headcount. And so we would expect marginal cost, if anything. Does that help, Siobhan, answer your question?
It does. I mean, it provides clarity, and I'm ready to make a motion unless others have questions first. So I would like to make a motion that we would adopt the parity of coverage between Providence and Moda and Kaiser so that they are all treating double covered the same.
Do I have a second for the motion on the floor?
This is Sean. I'll second.
Did Jeremy return? Do I have a quorum, Ali?
Yep. The Jeremy.
Oh, good. Oh, good. Wonderful. Okay. Any questions? Okay, so I'll go ahead and go down the roll call. So Saban made the first. Dawn Watner.
Approve.
Thank you. Kate Nass, did you join us? And Sean is the second. Jeremy Vandehey?
Yes.
All right. Ali, did I need to vote? I guess.
Yes.
Okay, so I also am in favor of the motion. Thank you. Sorry, all right, so it looks like the motion carried, that the board has approved this action to create the parity of coverage across all, so that double coverage is treated the same. Thank you.
All right, great. Thank you so much. If we want to jump to the next slide, this next section, I'm going to pass it off to my colleague Emery, and it's forward-looking on this slide. It's also a little bit retrospective as we look at plan performance for 2021, and how that impacts the projections that we're making for 2023. So Emery, I'll pass it off to you.
Thank you. So this slide shows historical composite rates. So essentially the funding rate decisions made by the board on the left-hand side based on the premium rates for that year, as well as the census as of the time that the decision was made. So, for example, in 2014, that would be funding rates for 2014 based on, I guess, the fully insured plans as well as the self-insured rates, but it would, since the decision was made in 2013, it would be including the March 2013 census. And so that's those are the composite rates, the funding rates that are set and used by the agencies to pay for it. So it shows historical information from 2014 to 2019, and then 2020, there was, because of the Senate Bill 1067 and the savings achieved by that, there was this decision by the board to increase the funding to bring the overall funding up, as well as there's a premium tax impact in there as well. So that brought up the overall funding. In 2021, as we were starting the COVID pandemic, the board decided to actually reduce the funding, and so the final composite rate is shown there of the $1,607.63. So it ended up being a 0.8% increase. The 22 results with premium tax was about 3.3% increase, and so the final composite was $1,660.52. And then for 2023, what we show here is the preliminary rates. So this isn't the composite rate, but this is really the initial results of the renewals, as well as the first run through of the self-insured projections. And based on those costs times the most recent enrollment, which is January of 22, what we're saying is the funding right now, as it currently stands, is an increase of about 3.6%, or $1,719.53 per employee per month. So it is above the 3.4% limitation. So compared to that 1660.52, it is above that increase by about $1.6 million, which isn't a whole lot, but you are currently above the $3.4 million limitation. So we just wanted to give you a heads up on that. Right now, as it currently stands, there might have to be some board decisions as a result. But we will get updated rates. We will take a look at the self-insured costs. We will negotiate with the renewals, with the vendors, Kaiser and Willamette and others. So potentially this number could change. It could go up, it could go down, hopefully down. And you may, as we restate it next in the next meeting, it may actually be below, or we'll see what it is. There could be changes to that number, but currently you're about 1.6 million above the 3.4% target. Any questions? Nope. Okay, so moving on to show you some of the self-insured plans experience. For statewide, the surplus was actually quite big in 2021. So it's about $39 million in surplus. The claims came in pretty low. The loss ratio was pretty low. And so as statewide had a better year than expected in the case. So the loss ratio was actually below 90%. The next slide shows you choice. The experience for choice was not as good. The surplus was about 9.2 million. The loss ratio was 97.1. I think the cost, based on our expectations of where maybe due to COVID and some of the impacts, costs are a little bit higher. And as a result, I think on one of the later slides, will show that the choice rate increase is a bit higher than some of the other plans. Moda's on this slide. Surplus was pretty good. Loss ratio was about 91.4%. So in between statewide and choice. And so their funding rate increase for 23 is between statewide and choice. Next two slides. So dental, there was a bit of a surplus. Loss ratio is 95.6. Dental trend is not as high. I think what we found for dental, at least for Mercer, is that 21 is a pretty decent representation of what's been happening, or what we might expect as kind of like the new normal. So we haven't been applying as many or any COVID increases bumps. So as a result, the Moda dental rate is actually, I think, it's a small decrease if I remember correctly for 23. And then vision. VSP actually, I showed you some information earlier about their costs. They did develop a pretty good surplus. Vision did not bounce back as big as I think some might have anticipated. So right now we are projecting a bit of a decrease in 23 for Vision, but the plan ran pretty well. And I'll turn it over to Mitch for the next section.
Yeah, so this next section is pretty lengthy. So we have 50 minutes. I am sharing my screen, so I can't see your faces. So, if you have a comment or question, feel free to interrupt me. And yeah, we'll just kind of get started. So I like this slide because we have a couple new board members, and there seems like there's a lot of plans, but there really isn't. So kind of looking over on the left, I've split out everything that's up for renewal, and then everything that's in a rate guarantee. So pretty much everything's up for renewal. Life and disability with the standard, that is in a rate guarantee for, until the end of 2023. So the Moda, or the medical plans, Moda, Kaiser, and Providence. Providence, there's 2 plans, the choice and the statewide. Then there's the dental plans there, Moda, which has 3 plans, the Premier, the part-time, and then the PPO. Then there's the Kaiser plans, Willamette Dental Group, and then Vision. You have it with VSP, and it's also baked into Kaiser as well. So if you're a Kaiser member, you can get Vision there. The last 3 programs are the supplemental programs. So ASI Flex is FSA, Benefit Help BHS, Benefit Help Solutions, their COBRA administration. And then Canopy, which formerly was known as Cascade Centers. Those are the EAP programs. So this slide kind of takes Emory's composite rate and the slide we just looked at and puts a number to it. So over on the left, we have all of the carriers. Oh, I can do this. Okay, this is cool. We have all the carriers over here, the line of coverage, their admin fee increase. So this is just for the self-funded plans. The final premium increase. So this is what the actual accrual rate came in at. And then the actual dollar amount. And then the plan share of the composite. So you can see Providence, statewide, and choice. Those hold most of the members. Statewide has about 17,000, and then choice has about 19,000. So those are most of the plan costs. You can see choice is increasing 7.7. They had they had higher utilization, as we saw with Emory's slides. I think the loss ratio was somewhere around 97%. So they're contributing to 1.9% of the composite increase. Kaiser's coming in at 4.9%. We're still working with Kaiser on this renewal, so this is preliminary. Moda, self-funded, they're about 7,000 employees, and they're coming in at 4.7. Delta Dental, as Emory said, they did have quite a high or a normalized loss ratio, and we're starting to see dental claims normalize across all of our clients. So they're coming in at a small decrease of 0.7. Willamette Dental Group, they originally came in at a 0% increase, and we were able to bring that down to negative 2.5. Kaiser Dental is coming in at 3.4. VSP, small or quite a decrease there, almost 4%. And then the standard, like I mentioned, is in a rate guarantee until 2023. Okay, so we're gonna kind of take a step back and look at all the work we did in 2020 for the 2021 plan year, which just ended. So I won't go into too much detail here, but this is just prior programs that we implemented and some of the utilization. So Moda, starting out with them, in 2021, we implemented Moda 360. So Moda 360 is kind of their concierge and advocacy model. It helps members, it steers members, I guess, through their healthcare journey. And so you can see almost 15,000 calls were made to Moda health navigators in 2021 with high satisfaction rate. So pretty good metrics there. Moving down, specialty light. So this basically is allowing a 90-day supply or a 90-day supply instead of a 30-day supply for specialty pharmacy. And so small uptake here, 27 members are utilizing this program. Again, Moda's only about 7,000 employees, and those taking specialty medications is probably smaller than that. So 27 is quite a good uptake. And then the pharmacy benefit optimization. This basically says drugs that used to be covered under the medical benefit, we can now cover them under the pharmacy benefit. Really no member disruption, but we see cost savings on the back end. And so 5 medications have traditionally been covered under this. So small savings, but still of use. And then looking at Delta Dental, again, we removed the waiting periods on orthodontia. It used to be 24 months, and basic for basic services used to be 12 months. We got rid of that. Can't really tell who was eligible or who actually took advantage of this, but based on the census, about 1,800 people would be eligible for this benefit. So quite an opening to health or opening to care there. Kaiser and Providence, so smaller things here. So on Kaiser, we increased the vision hardware to be $200 per plan year. This was to make the plan match VSP, so making the plans more the same. Unfortunately, we can't tell who was able to do this because Kaiser's on a capitated model. So, and then on Providence, the Optum Ed Analyzer. And so what this is it's an emergency department coder. So it basically says if you go to an emergency department and it's coded as this for the severity level of X, does that severity level match what it was actually coding? Unfortunately, due to the pandemic and the drop in emergency departments utilization, this did not go in effect for 2021. And then the last one there, we excluded coverage for varicose veins.
So I just had a quick question. Even though the Optum ED Analyzer, we know that emergency room visits dropped, but we don't have an analysis of whether there was any upcoding though, right? Because that still could have happened with visits that came in. Is that right?
Possibly, yes.
Okay.
But we don't have any findings in this presentation.
Okay, that's fine. I just wanted to check on that because I know that was the issue before and why we wanted that analyzer.
Yeah.
Sorry.
And yeah, so Siobhan, yes, I mean, we will bring more information. I think we can bring more information about it to see if there's an issue. I think it's something that we look at in the utilization report every half year. So, but we can get more information on that for the next presentation.
Thanks.
So moving forward, so this is all the work we did in 2021 for 2022. It's quite an exhausted list, so I'm not going to go through these bullet by bullet, but you can see the plan changes we made to the medical plans, so Providence, Moda, and Kaiser, and then down at the bottom, all the work we did around fertility benefits and adding the $35,000 annual max, as well as the enhancement of gender affirmation coverage. So now, took a look back. So now we're going to look forward at 2023. And so this first part, we're just going to look at the administration fees. So over on the left, well, let me back up. So these are the 2 self-funded plans, Providence and Moda. Within Providence, like I mentioned, there's 2 plans, statewide and choice. Statewide admin fees are increasing 3.2%, while choice is increasing 2.6%. Over on the right, you can see Moda's base medical and RX administration fee is not increasing. However, they are increasing the Moda 360 program 3%. And then down at the bottom are the variable fees, which are pass-through fees, so they're based off utilization.
So this would again be for a future meeting, but I know in the past we've gone over administrative fees and why they are increasing and what we're getting for those increases and whether the increases are for their entire book of business. So anyway, I just want to make sure we're also paying attention to that in future presentations as we go through this renewal.
Yeah, that's a good point. And we talked a lot about this last year, and we benchmarked the administration fees for these 3 plans versus Mercer's book of business. And we've seen typically that these fees are a lot higher than we're seeing in the market. So that's a good point, and we can kind of bring up some more information about why these are increasing in round 2. The Kaiser fully insured plan is increasing 4.9% or 7.3%. We have talked to Kaiser late last month, and so we had some questions on their underwriting, so these possibly might change for the March meeting. And then down at the bottom are some enhancements that Kaiser has for 2020, or actually some of them are going in effect in 2022. Others are later down the road. But right now they're enhancing their e-visits with chat through a clinician. So what this is right now when you do an e-visit, it's kind of like AI takes in the call and then triages it out. So for a little bit more complicated cases, you can still go through the e-visit, but you also now could be channeled to a physician where you can chat with them. So, typically we see a lot of people use virtual care when it's like, I have bronchitis and I know it's bronchitis and I just need this, or I have strep throat and I just need a Z-Pack. So this is for a little bit more complicated cases. So you, instead of just going through the e-visit and being triaged out, you can actually talk to the physician and, talk about if it actually is strep throat or if it's something a little bit more serious. Increased digital engagement. Basically here, they're allowing more through their app and things, more reminders, more push notifications and things like that. And, when you're ready for a flu shot or your pharmacy is ready to be picked up. Get Care Now is kind of like chat with the clinician, but a little bit different. It's for more urgent cases. So it says right there in the first line, 24/7 urgent care on demand. So, something happens, you can get on a phone call, a video chat, or talk to a physician and talk through what you're going through versus going into an urgent care center. And then one thing I forgot to put in here, but on chat with the clinician, they're actually expanding this to pharmacy as well in Q2 2022. So now we're going to talk about some of the self-funded plan considerations. And so these are a bit lengthy. So again, feel free to just stop me whenever you have a question or something's not clear. So starting out with Providence. So Providence is recommending a manufacturer coupon program. And so this is for pharmacy drugs, specialty pharmacy drugs to be specific. And we've seen this a lot in the market. Other insurance companies, pharmacy benefit managers in particular, are coming out with programs like this. And so what it is it's a coupon program to help maximize savings and lower member cost share. So I'll give you an example of how it works because it's kind of confusing to just read these bullets. So if I'm taking a $1,000 drug right now, and I'm not signed up for this coupon program, I'm not using a manufacturer coupon, I would just pay normal cost shares. So I would pay the $100, if I'm on the statewide plan, I'd pay the $100 specialty copay. If I am using, so then this manufacturer RX program coupon comes in and they automatically sign you up for this program. And it's like, hey, Mitch, you're taking this drug and it's $1,000, but there's also a coupon for it. So the coupon is $900, and that $900, so $1,000 drug, get a coupon for $900. That $900 basically satisfies my cost share. So my cost share goes down to 0. And the plan is saving money because where they would have been paying the other $800, they're now only paying $100 because the coupon covered the rest. And so that's kind of just a drilled down explanation of it. The $8 million worth of savings, it's a lot of money. We're seeing that because, again, specialty drugs are very high costs. We're lowering member cost share, but on the back end, that coupon, manufacturer coupon, is being applied to the plan. So it's savings really to the plan there. We're recommending that Pebb accepts this program. However, as Emery mentioned, our composite rate is still preliminary, so we'll go back and refresh these numbers. So it could be a little bit different. Does anybody have questions on that RX program? I know it's a little confusing sometimes.
One of the things I just wanted to clarify, the additional program enhancements are things that we would be voting on separately as part of the renewal process, or are they program enhancements that are part of the rate increase they're suggesting here?
So the top green line is the status quo renewal, and then the bottom blue line is what the rate increase would be if you accepted this program. Typically, we'll wait till the later board meetings to actually go through these programs one by one and approve or disapprove when we have final numbers.
Okay, I just wanted to clarify that. So that was true with the Kaiser slide too, and will be for the Moda slide.
Yeah, so, that's a good point.
Okay, thanks. And then I know, Emery, you had mentioned we'll look at utilization at the March board meeting. And I just want to make sure that as we're going through this, we're seeing where we're seeing cost increases due to prices going up versus utilization going up. So I think that's going to be a really key part as we pay attention, because, you know, a 7.7% increase for choice is really high. And we've continued to see high increases for choice, higher than the other medical plans in the last few years. So, you know, seeing those trends is helpful too. And I know, you know, the same will be true for Kaiser and Moda as well, but we'll want to see that for all the plans. Thanks.
Okay. Yeah, we'll definitely take a deeper dive into it and provide a little bit more information and take a look at especially choice in particular. There are potential savings. I mean, the expansion of site of care that they're working on, and you know, I mentioned the coupon program would potentially help save money to offset that. But we'll dive a little bit more into it. I know it's a hot topic for this board, especially.
And Emery, we'll want to do an equity assessment as well on some of the all of the plan design changes, really. So we can talk more about that. But
okay, yeah.
Okay. And then down at the bottom are additional program enhancements. So prior authorization for outpatient hip surgeries. So right now this is in place for knee surgeries, but essentially if you go to a doctor and they give you prior authorization not to have it inpatient care, you can do it outpatient care. And so I think as we start to see knee replacements and hip replacements be a little bit more routine, we can kind of push them out to these outpatient centers while still looking at the quality of the center, but also saving in costs as well. And then expansion, the next kind of 4 boxes are things that Providence is working on. So expansion of site of service. So working on moving orthopedic, neurology, gynecology, and ears, nose, and throat procedures out to ambulatory services versus inpatient. Expanding site of care for oncology. So instead of going inpatient to receive your transfusions for oncology drugs, you could do that in an outpatient center. And Moda actually has something that they're ready for on 2023, but we'll talk about on the next slide. Optimizing rebates for biosimilars. So basically getting kind of a drug that does the same thing, but there's more of a rebate on the other one. So where it makes sense to kind of push members to those biosimilars. And then concierge 90 RX 90. So this is incentivizing drugs to be delivered to your home at a 90-day supply versus going and getting a 30-day supply. Okay, so now looking at Moda. So looking at the first one, site of care. So kind of how I mentioned on the last slide. So Moda has these site of care programs where it's essentially moving a member from an inpatient to an outpatient facility. And it's not necessarily disrupting the member's drug that they're getting. It's more of saying, okay, instead of going to a hospital where you're paying a lot more, you can actually go to these outpatient centers where it's a little bit cheaper. It's the same care, although it's just an outpatient center versus an inpatient center. So right now, this would the oncology expansion would target about 14 therapies affecting 6 members. It would be about $125,000 worth of savings. And so we kind of recommend you guys look at this and implement it due to minimal disruption and achieved cost savings. Their copay assistance program, so this is similar to the Providence one. It's just Moda, if you use a coupon on Moda right now and you pay nothing when you use this coupon for your drugs, you actually, those cost shares that you would have incurred had you not used it still apply to your out-of-pocket maximum. So the member's paying nothing right now, but they're still meeting their deductible or RX deductible and their out-of-pocket maximum, or hitting targets on there due to using the coupon. So Moda brought this to our attention and recommended maybe we don't apply the cost that a member did not incur to these accumulators. We're still analyzing this further because it is technically a takeaway from members today, and the cost savings is only $10,000. So not sure if it's worth disrupting these members for minimal cost savings. The last one that Moda recommended was diabetic testing supplies. And so this is getting your glucose monitors and things for diabetes at a pharmacy, a retail pharmacy, versus a durable medical equipment provider. And so currently 56 members on the Moda plan are getting their medical or their diabetes medical equipment through these durable medical equipment providers. Had they switched to a retail pharmacy, the estimated savings is about $50,000. We're recommending that Pebb implement this change because it is such a small member population that would be disrupted, and they would be moving to retail pharmacies versus these durable medical equipment providers. So retail pharmacies like CVS, Walgreens. And so that was the 3 for Moda. Did you guys have any questions on those 3? Okay. And then additionally, Moda is enhancing they talked about this in the January meeting. So basically through Moda 360, they're enhancing their behavioral health provider network, and basically they're doing the 4 bullets kind of over on the right. What this enhancement is guiding and assisting members to finding providers that are not only in network, but actually accepting patients. They're following up with these members to make sure that they're actually getting the right treatment, going to treatment and continuing treatment, or if they need a triage out. Additional enhancements are support tools and aids. So they have what they call these behavioral health navigators, I think is the term they used, that are basically guiding the members through this journey and ensuring they're, getting the right care and what kind of care do they need. So it also expands by more digital health point solutions. So like bringing in, more digital, you can do a video chat versus going to an in-network provider and things like that. So there is an additional administration fee for this and some claims costs. So we're working on Moda to talk about this, and we might have some more information in the March board meeting. So that wraps up the 2 carriers, the self-funded carriers. The next couple items we wanted to talk about were diabetes prevention and breast reduction, medically necessary breast reduction surgery. So starting with diabetes prevention program. So kind of the background of this. So for 2023, we're looking to basically get more of a cohesive alignment between the 3 carriers on diabetes prevention and having them meet minimum requirements so that whether you sign up for Kaiser, you sign up for Providence, you sign up for Moda, there is a solution for diabetes prevention that is cohesive and equitable between all 3 plans. And so how this kind of came up and about is Canary, the previous DPP provider for Providence, which holds most of the members, actually sunset their DPP program last year. And so now there's this huge gap in care on Providence for these members who, were using this DPP program. Providence also does have other DPP solutions, and they also have Virta Health, which is kind of a diet program that helps, prevent diabetes, but it's not It's not the same as the traditional DPP programs that we typically see in the market. So what we did is Mercer and OHA staff worked with the National Association for Chronic Disease. We also looked at, white papers within Mercer and different programs that we're seeing within our specialty health practices to kind of create minimum evidence-based requirements for the carriers to have a DPP program in 2023. In addition to these minimum requirements, we also set other programs we'd like to see, like performance guarantees, digital interfaces, or like equipment like scales and monitors. Those were not required, but the things that were required were, okay, this program has to be at minimum CDC recognized. And so we said that because we want, again, the plans to have similar offerings. Again, some of the minimum requirements were around member reach out, member engagement, and other items along those. And so we set targeted metrics that we would like the carriers to meet. So kind of from this preliminary round, Providence and Kaiser both met our minimum requirements. So Kaiser offers Moda, which hits all of our minimum requirements. Providence, they offered a DPP solution that they could build. However, they are looking at outsourcing it too. And the program that they're looking to outsource to hits all of the minimum requirements. Moda did not meet minimum requirements by being CDC certified. So it's kind of an update where we're here now, and we'll have more information in the March board meeting. But any questions on this program? Okay. The next one, we're looking across all three health plans as coverage for medically necessary breast reduction surgery. And so I believe this came up last year as one of the member complaints, because technically this coverage is on Kaiser, but it's not on the other two plans. And let me back up and talk about what the coverage is. So there are three types of medically necessary breast reduction surgery. There's treatment for a transgender man as part of their gender affirmation treatment. And then there's treatment for women with breast cancer who unfortunately go through the hardship of having breast cancer and then need to make a decision. And then there's the third one, which is the one we want to talk about, is treatment for cisgender women with other indicators such as back pain. So currently the first two, for gender affirmation and breast cancer, those are covered on all three plans. Treatment for cisgender women is currently covered on Kaiser, but not on Providence and Moda. And so looking back, I believe in 2012, it was covered on all three plans, but due to some cost-cutting measures, we actually excluded it from Providence and Moda. And so the cost impact here would be about $400K for Providence and about $185 for Moda. And again, all three are already covered on Kaiser. Okay. So any questions? That kind of wrapped up that section. But any questions on the medical plan changes or proposed plan changes? Okay. So now looking at dental and vision. So Delta Dental of Oregon, also Moda Dental, their admin fee is increasing 1.7. And I believe their overall accrual increase is a small decrease of 0.7, which is this green number right here. Just a quick update on some enhancements. Delta Dental of Oregon is updating their provider directory. So it's just an enhancement that can kind of help categorize dentists by quality, as well as cost and patient satisfaction. One program that Delta Dental of Oregon is recommending is that Pebb increases the orthodontia benefit from, I believe today it's $1,500 to $1,800. Yep, it's right there. And so it's a small cost impact of $400,000. And so our kind of recommendation behind this is to increase it is, okay, benchmarks for from the Berkshire benchmark for state governments 500 plus is about $1,600. So you're a little bit leaner than benchmark. And traditionally, we do see that the annual maximum actually matches the orthodontia max. So the maximum right now is for the dental plans $1,750. So increasing that $1,500 ortho to $1,800 would then kind of match the annual maximum for other dental services. And again, it's a small decrease year, so there is some wiggle room there to increase to take on that $400,000. Kaiser renewals. So the dental renewal is coming in at 3.4%. Again, still a preliminary renewal. We're hoping to have more final numbers in the March and April board meeting. But down at the bottom are some enhancements for Kaiser. So some of the digital enhancements. So right now, members who are, well, used to be, so members who just selected Kaiser Dental and not medical didn't have access to the Kaiser app to go in and schedule appointments. Now they do, and they can confirm, cancel, and do all that within the app. They're also doing more push notifications under member enhancements, checking kiosks at dental facilities within a medical office, and then members can cancel or check in for their appointments 24 hours in advance. Virtual dentistry enhancements. So this is not Kaiser shipping some pliers to members and saying, here, just rip your tooth out. It's more of, you know, I'm calling in and I have a toothache and it's 9 o'clock at night and I can't make it to a dentist right now. What can I do to help ease the pain? And so this is currently in effect right now. There's just some small enhancements, making it 24/7 phone advice. And then members can now connect with their dental provider via secure email versus, you know, or the mobile app, which will go in effect Q3, Q4 of this year.
I just had a quick question on the Kaiser, since I know, you know, that's the one that's going up compared to the other dental. And we had, you know, extensive reporting on dental in the past. And one of the big things around Kaiser is it's a fully integrated system. So it'd be helpful to see how that's supposed to be helping with prevention and keeping costs down too, with additional services that people have. You know, if they go to the dentist, that's supposed to be flagging potential diabetes or other things that could come up that could be flagged through the dental care. And I mean, it doesn't look like, I would like to see how that's going to impact costs, because that's, you know, it's all part of prevention.
Yeah, that's a great point. And I know, you know, Kaiser, I believe they, you know, they're integrated care model, so it can kind of help push out to different areas. And I believe when I was working at Kaiser, they were doing this program where you could have your when you take your child in for their preventative or their cleaning, you could also, you know, possibly get a flu shot. And so looking at programs like that and how they're kind of pushing and triaging out to medical.
Thanks.
Willamette Dental. Oh, sorry. Is there another comment?
Yeah. Just a question, a process question. On all these enhancements across all the plans, this is my question. Are all of the enhancements, do they require board action, or are some of these just kind of like, hey, this is something they're thinking about, you know? Can you help us understand?
So most of these are things that they're doing. There's no cost to Pebb. There's no board action. Really, if we go back to these slides, so items in these kind of sections require board action.
Okay. That's what I thought, but I realized that I wanted to clarify when we were down the road here. Okay, good. Thanks.
Yep. Yeah. And there might be a couple where they are trying to build out the program, and there's going to be additional costs. For example, I think the Moda behavioral health, they're building out a program to really improve the behavioral health, and I think, if I remember correctly, they are would like board action to help, I guess, pay for those enhancements. We're talking to Moda about it, and as we get more information, we will bring that to the board for your decisions.
And then the last one we have is Willamette Dental. So I think I mentioned this at the beginning. It's a 2.5% decrease, negotiated down from a 0.0% increase. One of their enhancements that they're offering for 2023, again, no board action, which they're currently doing today, is for members who have never been into a Willamette Dental office for preventative cleaning. They're waiving the $10 copay, and so they'd like to extend that into 2023. And so it looks like through the first of this year, January 1st through February 7th, there were about 226 patients that actually took advantage of this. So got them in for their preventative visit, which is good. And then the last one we have is VSP. And so preliminary budget rates are a 3.9% decrease, and the administration fee is flat from last year. One of the programs that VSP did recommend, other than the one we talked about earlier, which will bring more information on that one, is the frame allowance. So currently, the frame allowance right now, if you go to Walmart or Sam's Club, is $80 on the base plan and $125 for the plus plan. VSP is recommending that you increase that to match what the normal cost shares are. So $150 on the base plan and $250 for the plus plan. There's no cost impact for this. And then in the last 12 months, we saw about 378 claims were purchased, or frames were purchased out of Walmart. So again, in talking with VSP, typically we see lower frame prices at a Walmart or a Sam's Club. So again, this is kind of giving members an added benefit for zero cost shares, or for zero impact to the rates. And so then that kind of wraps up round one renewals. So for the next board meeting, again, we have a couple takeaways here that I've jotted down, as well as we'll review round two of carrier responses. We'll go into more depth about the diabetes prevention programs and the medically necessary breast surgery that we talked about, as well as provide updates to the overall budget and the updated composite rate. Did anybody have any other questions as we wrap up? Great. Let me figure out how to stop sharing screen quick. There we go.
Thank you. Okay, so we are at 11:36 and we have a 10-minute break that we will go ahead and take. So it looks like Brian and Teresa will be starting your presentation a little bit sooner. So let's go ahead and 11:37 to, let's just go 11:50. We could be generous here because Mercer gave us the gift of time. So 11:50, let's get back and we will get started with PMAC's presentation. Thank you all. All right, it is 11:50, and not that I'm a taskmaster, but we got that gift of time, and I'm going to continue giving it. Thank you so much for joining us back here at the Pebb board meeting. And we have the pleasure now to have PMAC and the Worksite Wellness Council, Coordinating Council. They want to kind of build a framework and have a discussion with us and deliver that. And I think if memory serves me correctly, we have bumped you before, and I am just so grateful that you're on the agenda and you're presenting, and we're even starting you early. So thank you both so much for being here.
Thank you, Kimberly. I'm glad it worked out well too. I've made arrangements with my a vendor to come and do pressure washing outside my house today. So I timed it to coordinate so it wouldn't overlap with this presentation. So it all worked out. Good afternoon, board. I am Teresa Cross, Pebb's Wellness Manager. I staff the Worksite Wellness Coordinating Council, and I also work closely with Brian Olson to support PMAC, the Pebb Member Advisory Committee. We're here today to share a few updates to the well-being framework you saw a few months ago. In November, the board heard a presentation by Brian and Dr. Stephen Noldner with Mercer on PMAC's assignment to define the scope of, recommendations for, and possible challenges to a future health engagement model program. After hearing the presentation, this board recommended that PMAC and the Coordinating Council align their work. Each group has their specific charge. However, in some areas there is overlap. And in addition, the tasks of the Health Equity Work Group also intersect with the Council and the PMAC's work. And you directed staff to develop a plan for how each of these groups' work would be coordinated. So Brian and I worked with Dr. Noldner and his team to develop a well-being framework aimed at capturing the elements of PMAC, the Council, and the Health Equity Work Group, where they intersect and where they can complement one another. The Council saw the first iteration of the framework at their December meeting. The Worksite Wellness Coordinating Council did. They approved the plan, and they also urged Pebb to accelerate implementing that framework. In their words, plans are important, but Pebb members need help now. PMAC saw the framework in January, offered their feedback, and gave the plan a thumbs up. Based on PMAC and the Council's feedback, Dr. Noldner and his team, Brian and I made further adjustments to the framework. You will see today what we and both advisory groups think is a final plan that describes our work over the next year. Brian, before I turn it over to Dr. Noldner, do you have anything to add?
No, I'll let Dr. Neldner just pick it up and just let me know if there are any questions. I'll certainly feel free to, jump in as needed, and you let me know if you need me to speak up.
Thanks. Dr. Neldner, the floor is yours.
Thank you, Teresa and Brian. Delighted to be here. Hello, board members. As Teresa said, this is a continuation of the efforts that you launched us into last year, at the end of last year, after hearing the HEM presentation. And as Teresa already mentioned, it was based upon feedback from the Worksite Wellness Coordinating Council and subsequent feedback from PMAC. And we've developed some working guidelines, a framework, if you will, that we think can get you where you need to go. So let's move forward to the next slide, please. And I'm going to share with you at a high level what we're trying to accomplish. So you can see that we've identified, and again, this is from feedback from the Worksite Wellness Coordinating Council and PMAC as well, that employees are struggling right now. You know this as well. You're seeing it in the healthcare data. Your cost trends, your utilization trends are all impacted by COVID. And as well, the definition of the work site is different and it's changing. And that's one of the challenges that the council has been tasked with addressing in an evidence-based way. So we recognize there's some needs in the current state. In the future state, we want employees to feel supported. We want them to understand that regardless of where they work and what their challenges are, and including viewing that from a health equity lens, we want to be able to provide them with the best possible support. So with that in mind, we have outlined short-term, intermediate, and long-term goals. And the short-term goals really are to, as soon as we can, and we're in the process of this now, we'll elaborate it more as we go through this discussion, but immediately to identify what's currently available from the carriers and your other vendors in the way of well-being services and programs. And then at the same time as we identify those and vet those, we want to be able to promote those. So we are working on a communication plan, promotion plan that will quite quickly get this information out to individuals so they can easily understand what's there for them and how to engage in it. Then, as Teresa mentioned, the council and we all recognize that having a strategic plan is important. All ideas are great ideas, but they're not necessarily appropriate ideas unless you have a strategy that you're trying to follow. So, for example, we know that you're getting lots of different inquiries from different vendors and services that might be of interest, could be of interest to the board and to Pebb, but without a strategy, you don't really know if it's a good fit. So having a strategy and a strategic framework, you'll know, and we will know how to bump up those ideas against the strategy and decide if they're appropriate or not. So strategy is important for many reasons. So intermediate term goal is to identify a multi-year well-being strategy, and then in longer term, of course, execute that strategy in concert with the HEM model that you've seen, and also working closely with different collaborator groups, PMAC, the Council, of course, Uplift Oregon, and others. I'll pause there and see if anybody has any reactions to that very high-level introduction. And if not, we can move on to the next slide. So here's a visual to try to give you some sense of where this is going. And intentionally, it's not a straight line. It's a sine wave line, I should say, showing that there will probably be peaks and valleys throughout the course of this because there are different stakeholders that will need to be engaged at different times. But you can see that we're starting out in this early phase 1 and 2 of discovery, what's available, and communication of that. And overlapping will be strategy development. So soon after we get the inventory and promotion of existing services kicked off and underway, and it already is, we'll start gathering the right stakeholders for development of strategy. And then, of course, throughout the course of developing that strategy, we're listening to stakeholders and employees as well to hear what they're experiencing now and what they would like to experience. And ultimately, as this strategy process unfolds, we'll be looking for the board's approval and, of course, socializing this with other collaborating groups. And then finally, sometime into the future, we need to execute on that strategy. So this can involve enhancing or providing framework and guidance for the agency's individual wellness plans. It can provide what we call business requirements that your vendors and carriers will need to be able to deliver, and that may come to a need in the procurement process to find a unified well-being vendor, a platform that all things can come together on, as well as other services that you might consider and incorporate. And then as we continue to unfold the strategy, we'll be looking for other ways to refresh that strategy and find ways to fine-tune it throughout the course of time. And again, the implication is this is going to take some time. We're going to get started, and we are started right now in the early phases, but it will take some time to get all collaborators to have a voice and to do this in a way that makes sense for your organization. Any thoughts or reactions to that? All right, we can move to the next slide, please. We've outlined the different stakeholder groups, at least at a high level. There are others, of course, that we've acknowledged already and will continue to acknowledge through the process, but these are some of the core collaborators as we see. You, of course, the board overseeing all of the activities, and we intentionally insert the health equity work group to be an oversight or a vetting kind of responsibility in monitoring everything that we're doing around health and well-being and your benefits designs, as you know, as well. And then, of course, we've already introduced the Worksite Wellness Coordinating Council and the Pebb Member Advisory Committee, both of which are already taking action and will continue to take action per your direction. Next slide, please. we thought it'd be a good idea to take a look at and depict in a visual way how we really do see intersectionality among the different tasks and, of course, the different work groups. We view these all as collaborators. And we know that when they work together, when these groups work together and others that will engage along the way, that will get the best possible result. So you can see in the early discovery and promotion phase, this stage that we're in right now, the health equity work group is going to be working on overseeing and looking at the different services from their health equity lens. The Worksite Wellness Coordinating Council and the PMAC will both be doing some of this work individually and collectively. We have a number of joint meetings planned, and I'm going to turn it over to Brian and Teresa to offer some examples of that in a moment. But generally speaking, both organizations, both groups are going to be working on this in their own ways. We'll give you some specifics. And then the next phase will be strategy development. As we mentioned earlier, we'll identify stakeholder group to come together for that. We'll determine governance of the process, who will be accountable and responsible for overseeing the well-being strategy going forward. And the various groups will participate in that effort as well. And then finally, the execution. And you can see that the work has really just begun once you have the strategy developed, right? Because now people will be socializing it with their colleagues, with other stakeholder groups, and that health equity lens will be applied continuously to anything that is added to or flows from the strategy and its execution. Brian and Teresa, would you like to offer any examples of some of the collaboration that's already occurring between the council and PMAC?
Sure. At a high level, so Teresa Mercer and I have been working to coordinate kind of our next 3 to 4 months worth of committee and council meetings. And so we are going to have our medical carriers come and present to PMAC in March, and we will invite the coordinating council to that presentation. And we've asked the medical carriers to share their observations on what sort of challenges they think our members have experienced through their observations, both pre-pandemic and then qualitatively how that's changed since the pandemic has started, in addition to just other thoughts they have on ways that Pebb could help address those challenges. In addition, we're going to have EAP and potentially some HR-related presenters be invited to the Worksite Wellness Coordinating Council meeting, I believe in April, Teresa, if that's correct. We will be gathering the same sort of information. PMAC members will be invited to that meeting, so that way there's kind of some cross-fertilization between the two committees, and neither group is left out of the kind of information gathering process. For April PMAC's meeting, we will probably close the loop on the initial information gathering by sharing some additional member feedback and experiences. We do have a PMAC meeting this Thursday, and part of that will be sharing some initial member stories and experiences and challenges that I've compiled, in addition to Michael Garrett from Mercer sharing what he's observed through his work. And then we will probably need a little more time to gather some additional Pebb specific member feedback, and that will be brought back to PMAC probably in April, again with the Worksite Wellness Coordinating Council invited to that meeting. I think how this impacts the board is right around April or May. I think both the council and committee will be ready to ask staff or the board to highlight certain programs that are already currently available to members, and to find ways to get kind of connect members to those programs to address kind of those immediate needs. And then we may also, if we identify any new programs or program modifications with the carriers, members, and EAP through this process, we will take those sorts of new recommendations or program modification recommendations through the health equity process, take it through the health equity screening tool. And Teresa and I will need to figure out what that means in terms of when it comes back to the board for final decision. But that is something also that will come to you guys, the decision makers, at a certain point this year. So I'll stop there. That was a mouthful. Any questions?
I did want to let the board know also that in terms of the promotion and communication campaign that Dr. Nelder mentioned, that has already gotten underway. One of the aims of this plan was to highlight the work of the coordinating council and kind of elevate the awareness among Pebb members of what this group does on their behalf. And so in the monthly newsletters that Mercer helps Pebb compile for members, the council now sponsors the wellness webinars and wellness events. So those aren't, that's just one more way to get the council's name and responsibilities out there.
Thanks, Brian and Teresa. And that's a great segue, Teresa, to the next slide. If you would advance, please. Where the next slide, we're talking first about some of this early inventorying activity, and then we're going to give you an example of some of those communication activities that are already going on. So again, some of the things that we're trying to accomplish is understanding what exists right now that's readily accessible, easy to access, and ideally evidence-based and useful for people to get involved in as quickly as possible. So identifying and inventorying is what we're doing right now with the efforts that you heard Brian outline and others. And then we're going to compile the evidence for that, the research evidence to corroborate that those are useful and meaningful services and activities for your population, create that communication plan, and certainly make sure that we are keeping all appropriate stakeholders informed and supportive. We'll need the voices of everyone from the highest levels of the organization at the governor's office to the worksite wellness plans for the agencies to all be working together to make this happen. And of course, moving forward, we'll want to make sure that everything aligns and hem-aligns with these activities and trying to really get people to engage in the services that are important for them. So next slide, please. Here's that example of the promotion plan that's already underway. And Teresa just outlined that already in January, Pebb month, there was a wellness month in January, and branding from the Worksite Wellness Coordinating Council has been included with a logo and a tagline. Will be included. It's under development right now, but it'll be a branding that will be identifiable and applied to all the kinds of services and programs that the council has reviewed for evidence-based design. And as Teresa said, it's really a great way to get people to look at this icon, if you will, and immediately know that this is something that has been vetted and recommended to membership to actively participate in. And you can see other examples throughout the course of the year with a wellness month in July and regular emails. And we understand the limitations of your email system, so I don't want to say that when I say regular emails, coordinated and planned emails, not daily blasts. So I just want to be clear that we're not going to inundate people, but that's part of the challenge of promotion and communication is identifying appropriate channels and the right cadence of messaging and the right type of messaging. And all of those things are things that we're working on right now. Next slide, please. And by the way, please interrupt and ask any questions that you might have along the way. This is just a slide that shows that we really did solicit feedback from the Coordinating Council and PMAC to really get their reactions to what we laid out here as proposed. And as you heard both Teresa and Brian say, both groups really fully embraced this and are excited about participating and charging ahead with their efforts that will be crucial to the success of all of this. Next slide, please. And we are going to give you a chance to give us feedback as well, of course. So I'm going to take you through the presentation here, and we'll give you that opportunity to provide us the feedback. Just at a very high level, this is the plan for strategy development, phase 2. Again, we'll start in several months from now, but we'll identify and assemble key stakeholders. We'll confirm the governance structure that will be accountable and responsible for the overall strategy. We'll develop vision and mission and guiding principle statements. Then we'll develop a multi-year strategy, typically about a 3-year strategy because things can change drastically beyond that. And then a tactical roadmap that gets down to how we actually execute on the strategic framework for multiple years as well. And as I mentioned earlier, we envision, and you've heard this before, that the recommendation from PMAC was that we consider identifying a specific vendor that serves as the hub of all this activity, the consolidator of the different services and activities, so all people on the same platform. And what would come with this strategy project is the definition of those business requirements, so that when you develop the RFP, we'll be able to clearly identify what is needed from your vendors and carriers so that we can get the best possible fit. Pause there and see if anybody has any comments or questions or input. If not, we can move forward. And then, of course, as I mentioned earlier, it's really important that we do this in a way that is inclusive of stakeholders and hearing the voices of the people, understanding what they're challenged with now, what their needs are, and what their interests are, as well as these key groups that we've been talking about already that will work in collaboration and ultimately report to the board and make the recommendations to the board for approval. Then the facilitation of the process, get the message and that final strategy out to the agency for reference for their agency wellness plans, and other collaborators perhaps could use this as guidance as well. And then finally, communicate those business requirements to the internal partners and external vendor partners as needed through the procurement process and just generally working with your carriers and vendors. Next slide, please. And this is a very high level timeline just to show you that some of these activities will be overlapping with each other, but clearly it's going to take some time to get to the end result. And even when we get to the end of strategy and socialization and approval and starting on execution, there will be reviewing, revision, and continued development and refinement of your strategy over the course of time. And I just want to connect this to the earlier discussion and the question from one of the board members about what are we doing to manage our population health and the population health costs. And this is clearly an important piece. And of course, I have a bit of a bias because I've been spending my entire career in not only population health management, prevention, and treatment of disease as time goes on. But all those pieces work together. And if we can help more of your members get meaningfully engaged in the right services at the right time and get excited about that, develop healthier habits, then we know that medical cost trends can be mitigated by less demand and less need for medical costs if people are healthier. So this is clearly designed to be part of your overall strategy to manage to your 3.4% trend line into the future. Next slide, please. So Ryan, I think I'm going to turn it over to you to take us through some next steps.
Yeah, so I kind of let the cat out of the bag earlier on when I kind of rambled on about what we plan on doing between now and April. Sorry, I tend to get ahead of myself a little bit. But so what we'll be doing is if you guys have any feedback or suggestions, we'll be taking that back to our respective committee and council. We'll have them provide feedback, and essentially we'll update this plan and framework based on all of that feedback we receive, including whatever feedback you may have after I get done speaking. We also will identify additional stakeholders along the way, and this is part of our ongoing health equity development work, continuing to identify members or groups of members whom we may need to contact to solicit feedback, or whom we just need to incorporate into our decision-making process. And as I mentioned again, I think for the existing programs that the board has already approved, where we want to increase involvement or engagement with members. I'm not so sure we'll come back to the board in terms of a recommendation, but I suspect we'll provide an update on what sort of programs we want to highlight in our communications. We will come back, I believe, at a later time, probably mid-year, likely with some specific program recommendations or some program modification recommendations based on all of this work. I think it's still premature to talk about what that may look like because, again, we're just beginning to gather in the information now. And then I think at that point, too, we will be bringing the Coordinating Council and PMAC together mid-year like we did last year for an annual kind of survey presentation, a high-level presentation on Pebb's book of business to help get everyone up to speed. And Teresa and I will try to identify some additional conversations and decisions that need to happen with PMAC and the council at that time to help inform their work for the rest of the year. So long story short, we have our roadmap. We have a pretty specific idea of what we need to do between now and probably at least May. And then along the way, we're going to start identifying what the world looks like between June and December. And we'll be providing staff and you guys with updates along the way. Any questions or concerns? And Teresa, is there anything you feel that we need to highlight or that we didn't cover?
I don't think so. Thank you, Dr. Noldner and Brian. I just want to say that the council, I think, is very excited by this work. They've been challenged, as many of us have been, to try and define what worksite wellness looks like when the worksite has changed, and certainly the health and the world has changed for everyone in the last 2 years. And so this framework really defines the work, puts it into steps and milestones and benchmarks, and really defines our work in a way that the council can really sink their teeth into. So they're ready to go, and we're going to do the work, and we're going to share it with you, and we welcome any feedback you have.
Thank you.
Thank you.
All right. Any final questions for them?
I don't have a question, but I would like to say thank you personally to Brian, of course, Teresa and Stephen, in working with them over the last several years and getting us to where we are now, and look forward to what you're going to bring to us as the board. So thank you.
Thank you, Greg.
Thank you.
Yeah, I'll just add, I
Sean?
really appreciate the presentation and all the work that's gone in it. It looks like a great direction plan to keep going. So I didn't really have a lot of questions because it's like, yeah, this looks good. Look forward to the next steps and hearing about the progress. Appreciate it.
Thanks, Sean.
You. Yes, a lot of work has went into this. So thank you so much. And again, thank you for being here. And I'm just so glad that we were able to honor your presentation and no one was pushing you to finish early or anything like that. So thank you so much. Next up, we have, so Ali is going to present, and we're going to talk about the Pebb Booster Incentive payment discussion, and Ali is going to present. And then Ali, we can talk about the fact that I have in writing, if we need, when we do a vote, that we do have in writing from Jeremy, since he did have to step away. Thank you.
Yeah, that's correct. And just to give you a little bit of background first, in summer of 2021, last summer, the Pebb board offered a $100 incentive payment to Pebb subscribers, also known as active employees, who received at least one COVID vaccine shot by the end of the summer. Approximately $3.6 million in incentive payments were paid out of stabilization fund to about 36,300 employees, and they self-attested as to their vaccine status. So that's a significant number. That's about almost 2/3 of the total employees that we cover. While the state was successful in getting over 85% of employees initially vaccinated, the rate of booster shots has slowly increased and now sits at approximately 58% of Pebb employees who've been boosted. So the question I guess I bring to you today is, given the reserve surplus experienced in the 2021 plan year that we heard from Emory earlier, and the low percentage of COVID booster shots administered to Pebb subscribers, should the board consider an additional incentive program for COVID booster shot? Evidence, while there are studies showing the effectiveness of cash incentive payments and wellness programs, there's very little information available related to the efficacy of a COVID vaccine monetary program. Moda confirmed that they offered an Amazon gift card program to their Eastern Oregon CCO members that was very popular, and you saw the uptake above in our own offerings. So we do know that the governor's office and the Oregon Health Authority have set goals for boosting the population that have fallen short so far. As for an amount, you know, there seem to be a lot of people that take up on the $100 incentive. So I don't know if less or more, if anyone has thoughts on that or if at all, but talked with our operational staff on timing, and our systems and data people right now are focused on producing and mailing the 1095 tax forms that show your insurance coverage over the past year. You should be getting those here in the next 2 weeks. And we hope to wrap this up by the end of February. The booster incentive would be the next priority. So hopefully the first part of March. And duration of an offering would be determined, but ideally no longer than 2 months. And obviously our communications, we have a lot of support from our stakeholders, and can obviously get the word out as we did previously. As far as requested action, if the board is interested in a booster incentive program, it looks like we don't quite have a quorum. We do, however, have the majority of board members here, and if there is no quorum today, the board could delegate to board leadership to pursue an incentive program and report back to the board, which is how we handle the last incentive. So that's not a problem. As Kimberly mentioned, Jeremy had to leave to a meeting, but voiced his support for incentive program and to pass that along. So I guess with that, I can open it up to questions or comments.
I just wanted to make a comment on this because it is something I see through the lens of wellness, and how can we think about getting folks in the habit potentially of getting boosters. We don't know what COVID holds for us in the future and whether we're going to have boosters in the future, but we certainly see it recommended now. And we are seeing evidence that it does mitigate the impacts of COVID when people have had the first series and then the booster on top of that. And so thinking about it through that lens, I think any additional folks who may be incented to get a booster, I know that was the discussion that we had last summer, but I think that would be positive in terms of overall health for the membership.
I would also add that Pebb, has a role to play in being a state leader, and demonstrating that this is something that can be done, that we're doing, might encourage others in the market to do so as well. Just around leadership on that. It seems worth a try from my point of view, to get the numbers up, which are quite low on boosters. I have a detailed question. The incentive is just for members, like the employees, not for family that we are covering. Is that right?
That's correct. Mhm.
And Ali, that had to do with tax implications, right? We weren't
Yeah.
able to offer it outside of the subscriber. Is that right?
Exactly. Mhm.
Okay, that makes sense. Okay. Yeah, well, so that's what I think.
Yeah, I mean, I think the surplus that's been built up in over the last couple of years is like we talked about today, people unfortunately, not getting the some of the preventive care that we really want them to get, and that includes vaccine shots, whether it's flu vaccine or whatever, and the booster incentive, as we see it, would fall under that HIM program, and really trying to incentivize people to be conscious of their health actions and take at least two of those actions each year, and we would consider this as one of them.
And Ali, this would be basically the same as the other. You would fill out the form and it would come back into your check instead of us doing like a separate, which would cost more.
Yeah, it would actually be through our enrollment system, and it's a self-attest screen, and then it would show up, in the
Right. We wouldn't cut out a separate check, which would cost more. It would just come back into our payroll, correct?
Yeah, that's correct.
That's perfect. That's great.
And a lot of people have
questions.
I have one. A lot of employees already had to attest and have already attested at least to their primary series. I don't know about boosters. Could that attestation serve as the evidence that booster has already been obtained and received, so that it would be seamless for those individuals and also would support those who may have gotten it but not submitted, and those who haven't gotten their third shots or their boosters to go ahead and get those and submit them?
Yeah, that's an interesting comment, Don. I think we would have to talk about that as staff. I mean, we get, sometimes when it comes to programming, these screens, it can get pretty complex pretty quickly, and with our system at the age it is, it's not exactly the most flexible. So we would obviously want to incentivize as many people as possible. So we would have to take that into consideration and can talk with leadership. And what we would do is come back to the board and here's the plan and what we'd like to do, and take feedback.
Now that I think about that, as PHI, probably there is not easy and quick communication about it to anybody. That would need to be a member decision on a case-by-case basis with whom they shared that information. So I understand the complexity of it. I do think that there is good evidence that incentives can help people change behaviors, and I really like Siobhan's comments about helping to rebuild the muscle memory of getting back into the habit of taking care of ourselves and getting the care that we need, since we've all been afraid of healthcare systems for a couple of years now, for good reason.
So do we need to move this to board leadership, since we don't have a quorum to make a vote today, to make decisions in the absence of a quorum around instituting the booster incentive? And we didn't talk about changing the amount. I mean, I guess I would say we should stick with a $100 amount, but I don't know if other folks had thoughts on that.
Yeah, I'm fine with keeping the same amount, just to try for consistency, I guess. open to discussion. But I'm wondering if we really need a motion or what have you for the next step, because we're not really voting, I don't think, today to like approve, but rather it's sort of like, it seems like fairly obvious that there's a clear majority of the board is interested in kind of getting to the next step of details. So I'm wondering if we can just say that, can we move to the next step of details so that the next time the board does meet, perhaps we are in a position to actually make a decision or closer to it anyway.
Ali, were you thinking you needed it before the March 15th or March meeting? Is that what you were thinking because of the staff time?
No, I mean, we can move forward and start working on it. I think right now we're just looking for delegation from the board to work with board leadership and scope out the program and then report back before the next board meeting. And if needed, we can talk further, but we can schedule a 5-minute call if we want to take action on it.
I think you have the support.
Yeah.
I just wasn't sure if last time when we delegated support, if we even voted on that, we just delegated support and then the leadership moved forward without having to schedule a vote.
That's how it worked last time, Siobhan.
Right.
So if you're fine with that, we can do that again, and if not, we can schedule a call once we have details.
I mean, I'm fine with that.
Okay.
I'd appreciate that. If the rhythm of meetings is not the thing that is determining when things can happen, there are some other things that are more important in terms of determinations. And in this one, sort of the surge and presence of Omicron and the impact it's having on families ought to be the driver. And I appreciate that this might protect some of our employees in ways that we want that to happen. I am interested in the equity impact. However, I would like to be aware, not that I would throw this down as a barrier between now and proceeding, but to understand the uptake of the incentive the last time around, and if there was a differential impact across our membership on different groups, whether some benefited disproportionately, or if again there are groups who might require targeted outreach.
Yeah, there's limits, Don, to our. We're not quite to real D yet. We do have some demographic data, but it's again, our system is pretty old. We're in the process of replacing it right now, which we will have real D data, but we can share with you the health equity assessment or analysis that we did previously on the incentive, and I think that would probably give you a lot of what you're looking for.
Thank you. I appreciate that.
Mm-hmm.
I support the effort. I think it's a good idea.
Thank you.
Thank you. All right. Thank you, Ali. And Rose, did you have any public comment?
No, Kimberly, no public comment.
Thank you, Rose. And thank you so much for always taking such good care of us. We appreciate you. All right. Does anybody else have any comments or anything that needs to come up before I close today's meeting?
The only comment I have is we received an email 31 minutes ago that says there was a floor vote, and we will confirm.
Oh, yay! Congratulations to both of you.
And now I have to do training.
Yes, you do. And I love the binder, the magic binder, but the new Pebb member training. It's very nice. So yes.
Yeah,
well,
and
congratulations to you both.
I scheduled time with Greg yesterday, and Andrea and I think we meet later next week, and I'll be scheduling time with Dawn as well. And if anybody has any questions on the Pebb board member manual, Rose really worked hard on that, and I think it's got a lot of good information. So
It does.
For all board members, new or old. So yeah.
Oh, I printed it and I put it in I have my original from Kathy. I teased Kathy that she interviewed me and I interrogated me before I could get on the board, but she says that's not true, but so, all right. Well, congratulations. And again, we're very blessed with a great Pebb board. You guys are just incredible. Thank you to Mercer, and thank you to all of our partners with our plans. And I'm going to call this meeting to order and close this meeting. And thank you all, and we will see you again next month. Thank you so much, everyone.
Thank you.
You're adjourned.
Thanks, everybody.
Thank you.
Have a great day.